Okay, looking now at vertebrae like you did in lab. Most vertebrae have a standard set of features. And you can kind of think of a vertebrae as being divided into two parts. The anterior portion is the body, and the posterior portion is what we call the vertebral arch. And the arch is made up of the spinous process, the transverse processes, the lamina between them, the superior and inferior articular processes, and the facets on those processes. So the arch has lots of things that stick out. And you can really structure function, the vertebral body and the vertebral arch, and see that their structure is for very different kinds of functions. The vertebral body, when you look at it, it's big, it's thick, it's chunky, it's dense, and that structure facilitates the function of weight bearing, weight transfer through the vertebral column, through the intervertebral discs, all the way down to the sacrum and then lower extremity. The vertebral arch, made out of all kinds of processes, which we know are features that stick out, increase surface area. So there's a ton of surface area. If you trace your finger all along the edge of the vertebral arch, along the spinous process and the transverse processes and the lamina, lots of surface area there for muscle attachment, ligament attachment, and articulation. Excuse me. So very different structure function correlations. And we know that the processes on the arch are for articulation with other vertebrae, above and below, superior and inferior to a vertebrae, or for ribs in the case of the transverse costal facets on the thoracic vertebrae, and then lots of attachment for muscle and ligaments everywhere else. The body and the arch are connected, forming a vertebral foramen, which is a big hole at the center of the vertebrae. And that, of course, is for the spinal cord to pass through. And I should also mention that the pedicle, I always think of it as what connects the arch to the body. You can see the pedicle are right where the body and all those processes begin to connect to each other. So the most cranial kind of vertebrae that we have are cervical vertebrae. Cervical is a term that refers to our neck. We have 7 of them. And you remember in lab that there is a feature unique to only cervical vertebrae. It is the transverse foramina, 2 on each vertebrae, just lateral to the vertebral body. All cervical vertebrae have this feature, and only cervical vertebrae have this feature. When we look at cervical vertebrae in general, we see some other traits. We notice that the spinous process is fairly short, except for C7, our 7th cervical vertebrae. And the spinous processes are also sometimes bifid. If you look at that word, you see bi, meaning 2, and that means that the process branches into 2. And when you look at this stack of cervical vertebrae, you can see that there are varying degrees of bifid arrangement. Some really fork very clearly into 2 parts. Others have just kind of an emerging bifid spine. And this is a feature that increases surface area, so gives even more surface area for attachment of those neck muscles and ligaments, which remember have to be really strong to support and move the head. C7 is never a bifid spine. It actually has the longest spinous process and an additional sort of bump of bone on the end of the spinous process that is called the vertebral prominence. If you feel the back of your neck, there's one really big bump kind of right at the bottom of your neck, and that is always your C7 that contains the vertebral prominence. The vertebral foramen typically has a triangular shape, and that's going to be due to the shape of the spinal cord passing through it. And the body can be described as wide medial laterally. The articular facets on the vertebrae in each region of the column are going to be oriented in a particular way, and that's going to create a particular type of movement or set of movements in that region. So in our cervical region, we know we can flex and extend our neck. We can also laterally flex our neck. And then we do have that rotation, but the rotation is due to the unique atlantoaxial articulation. To get this range of movement, we see that the superior articular facets face supero-posteriorly, so they're facing towards the top and slightly towards the rear, and the inferior facets face the opposite direction, infero-anteriorly. And that's going to allow one cervical vertebrae to stack up to the next cervical vertebrae. Okay, we had two unique cervical vertebrae that we looked at in lab. C1, the atlas, C2, the axis. Notice that they do both have the transverse foramina, so they have that typical cervical vertebrae feature, but then there are other things unique about them. So C1 is called the atlas, and it's called the atlas because, like Atlas from mythology supported the world on his shoulders, Atlas, your vertebrae, supports your head. And there are two features unique to the atlas vertebrae. One is that it has no vertebral body, and the other is that it has no spinous process. And the absence of those two features really make the atlas look different than other vertebrae. The vertebral foramen seems so much larger, and that of course is because there's no vertebral body taking up any of that space. It also does not have that spinous process projecting from the dorsal side. Because of these major features missing, it has a few other features missing. There are no pedicles because pedicles connect the body to the arch. No body, no pedicles. And there's also no lamina because lamina are what sit lateral to the spinous process. No spinous process, no lamina. Instead, there's an anterior arch and a posterior arch on the atlas. Inside the anterior arch, there is a special facet that is where the odontoid process of the axis will articulate. Lateral to where the vertebral body should be, there are surfaces with articular facets. So these superior articular facets are different on this vertebrae than on all the others because they face directly superiorly. They're also elongated and a little bit cupped. And these facets really are the opposite shape to the condyloid processes of the occipital bone. So the occipital condyles articulate here, and that is why they are shaped uniquely. C2 is your axis, your second cervical vertebrae. Normal in every single way, except it has an additional chunk of bone on it called the dens or the odontoid process. Notice both of those words have a root for tooth in it. Odontoid actually means resembles a tooth. Process then telling you that it sticks out. Dens, like den for dentist, also refers to tooth. So anatomists felt this was a tooth-looking chunk of bone that sits superior to the body of the axis. All the other features are the same as we would find on a typical cervical vertebrae. And the unique articulation between the odontoid process and the anterior arch of the atlas allow for a pivot joint to rotate our heads. And head rotation is an important evolutionary trait that allows us greater vigilance, which means we can turn our head to see what's going on behind us, but keep our body in the direction maybe that we're going to need to if we were, for example, a prey species in the savannah, let's say. Think about it, there are some animals that cannot rotate their head the way that we can. For example, alligators cannot rotate their head. Then again, there's not much creeping up on an alligator that it needs to see in order to run away from. It may seem like a coincidence that there is a missing chunk of bone on the atlas, no body, and an extra chunk of bone on the axis, the odontoid process, but in fact, evolutionists believe that the odontoid process of the axis was formerly the body of the atlas and created this pivot joint through evolutionary processes to facilitate that rotation of the head. Okay, we have 12 thoracic vertebrae, and what's unique about thoracic vertebrae is they articulate with the ribs, right? They're in the thorax region, which is where the ribs are. So there are 3 sets of facets on each side of a thoracic vertebrae, a transverse costal facet on the anterior side of the transverse process, and then a superior and inferior costal facet on each side of the vertebral body, right near the arch. The superior and inferior costal facets are also known as demi-facets, demi meaning half, because 2 half facets create a whole facet for the head of the rib. So as we'll see in a minute, the superior costal facet on one vertebrae and the inferior costal facet on the vertebrae above it create a full facet. So 2 halves make a whole. It's important when you're talking about facets on vertebrae that you specify articular facet versus costal facet because they are very different. Thoracic vertebrae have a unique appearance, partly because their spinous process is elongated and tends to be pointy and project inferiorly. It's important to remember, though, that traits in one region are different than traits in another region. However, the transition from one region to the next is somewhat subtle, and therefore one vertebrae starts to look more like those in the next region as you move caudally. So if you look at this full picture of the vertebral column shown on the left, if you look at C7, your last cervical vertebrae, it kind of looks a lot like T1. It has that elongated inferior projecting spinous process. And if you look at T12, your last thoracic vertebrae, it looks a lot like L1. It's become bigger. Its spinous process is less inferiorly projecting and more kind of short and squared off. So there has to be a transition from one region to the next. And we see that in the shape of the features. Vertebral foramen is circular. Again, that's due to the shape of the spinal cord, which we'll talk more about at the end of the semester. The vertebral body has a heart shape. I don't like those shape descriptions. I find them to be kind of subjective and hard to consistently observe. But the articular facets do face specifically clear direction in the thoracic region. So remember, they were kind of facing supero-posteriorly and antero-inferiorly on the cervical region. Here in the thoracic region, the superior facets face really directly posterior and the inferior directly anterior. These articulations are going to allow for rotation in the thoracic region. So our vertebral column does flex, extend, and rotate. However, those movements are really significantly attributed to one region or another. So the rotation of your vertebral column is largely coming from your thoracic region. If you want to stand up and put your fingers on your thoracic vertebrae and rotate your thorax, turn your body, you'll feel the movement there. If you move your fingers down to the lumbar region and do that same rotation, you really don't feel the movement as sharply. And then we'll see when we get to lumbar vertebrae, this is where most of your flexion and extension occurs. So you can repeat that, putting your hand in thoracic region versus lumbar region and feeling where the flexion and extension is really happening. Okay, 5 lumbar vertebrae. These are the biggest, thickest vertebrae, and that is because they are the most caudal and we do the most weight bearing because the weight transfers all the way through cervical, thoracic, through the lumbar region to the sacrum. So they're thickest and biggest for the greatest amount of weight bearing. They don't have any special features. So remember, cervical vertebrae all had transverse foramina, thoracic vertebrae all had costal facets. How can you tell a lumbar vertebrae? It doesn't have any of those special features, just the normal vertebrae features. Its spinous process is kind of short, kind of square, kind of directly dorsal in its projection. Vertebral foramen goes back to that triangular shape, like we saw in the cervical region. The body is very large and often described as kidney-shaped, but again, I don't use those shapy things. And the articular facets, as I was just mentioning, facilitate flexion and extension, as well as lateral flexion, so bending towards the side. And the superior articular facets face medially, the inferior articular facets face laterally. This is pretty clear to observe on your lumbar vertebrae. And again, this is where we get that flexion, extension, and lateral flexion from. Okay, we have one sacrum and one coccyx. Remember, the sacrum was formerly 5 separate sacral vertebrae that do fuse together postnatally. Your sacrum articulates with the last intervertebral disc, as well as your L5 vertebrae, the coccyx inferiorly, and laterally the sacrum articulates with the ilia portion of each os coxa, and that's a thick, strong, weight-bearing, weight transfer joint. The whole sacrum is for weight transfer, as the weight comes down through the vertebral column and is passed along to the pelvic bones. The sacrum does have a body, as well as a sacral canal, which is really a vertical passageway that spinal nerves will move through as they get to the lower extremity into the pelvic cavity. The sacrum has anterior and posterior sacral foramina, so there are holes that lead to the anterior and posterior side of the body. Again, those are for spinal nerves. The sacrum does not have true spinous processes or transverse processes. Instead, it has little remnants, little bits left over from a typical vertebrae structure that, because of the fusion of the separate sacral vertebrae, create what are called crests. So there's a median sacral crest right down the dorsal side of the sacrum at the midline, and then lateral on each side there is a smaller lateral sacral crest. Little tiny row of bumps that used to be the various processes on a typical vertebrae. Your coccyx, formerly 4 separate coccygeal vertebrae fused together to make one postnatal coccyx, articulates only with the sacrum and has fewer features. It's really just for muscle and ligament attachment. Remember, there's no intervertebral disc between the sacrum and the coccyx because there's no weight transfer there. The coccyx is described as sexually dimorphic in its orientation, and we talked about this a bit earlier on. Essentially, the coccyx in a male curves sharply anteriorly, and in doing so blocks the pelvic outlet, makes a small opening for the pelvic outlet. In the female, the coccyx is described as straighter, kind of hangs back a bit more, and that is not going to block the pelvic outlet, leaving a bigger passageway for a baby to be delivered through. The coccyx is missing a lot of standard features on a vertebrae, including the vertebral body, the spinous process, and doesn't have any kind of opening or passageway going through it. Okay, so here you can see pictures of the sacrum and the coccyx, the anterior view showing you those fusion lines, those horizontal lines, so you can count out 1, 2, 3, 4, 5 separate segments. You see the anterior sacral foramina as well. On the dorsal side, you see that sacral canal, that passageway that runs through the dorsal side of the sacrum, and that kind of bump of bone running where spinous processes normally would be. That's called your median sacral crest. And then laterally, you have a smaller set of little ridges. Those are the remnants of transverse processes. Those would be your lateral sacral crests. Then you can see the coccyx, not too much to it, 4 segments fused together. You do see tiny little transverse processes there. No body, no openings, no holes running through it, no dorsal projections, no spinous processes at all. Okay. Moving on to some other bones of the axial skeleton. We did skull and vertebral column. Now we have ribs and sternum to look at, kind of making up the thoracic cage. So ribs, sternum, thoracic vertebrae, dorsally, and then the costal cartilages, which are the hyaline cartilage that connect the anterior side of the ribs to the sternum, form this unit called the thoracic cage that carries out the functions of course, protecting the organs of the thoracic cavity, like the heart and the lungs. Also creates the movement necessary for respiration. So when you do your respiratory system, you'll talk about the way that the ribs move to allow for lung expansion and to facilitate lung expansion as you fill the lungs with air. These bones make up two openings. There's a superior thoracic aperture and an inferior thoracic aperture. Aperture is a nice fancy word, basically for a hole or an opening. When I was a kid, I used to call my sister an anal aperture, just to get her mad. So an aperture is basically like an opening or a hole. And so if you look at this picture, you can see the superior thoracic aperture is where the neck is, leads into the neck. And that's an opening that remains opening. It's not sealed. Organs like the esophagus can run freely from the neck into the thoracic cavity. The inferior thoracic aperture, though, is typically sealed with the diaphragm, a big skeletal muscle that's important for respiration that you'll talk more about. And because the inferior aperture is sealed, any structures that have to pass between the thoracic cavity and the abdominal cavity, which is inferior to it, have to go through a specific opening. So there are several holes in the diaphragm that you'll learn about that allow for structures like the esophagus and the aorta to pass through from one space to the next. All right, so we've talked about the functions of the thoracic cage to protect thoracic organs. It is also supporting and really connecting to the pectoral girdle because the clavicle, which is part of the pectoral girdle, articulates with the manubrium portion of the sternum. All bones serve for points of muscle attachment. And then there's that movement for respiration. You can feel your rib cage kind of elevate and depress as you take a deep breath and then release that breath. So your sternum, which the layperson would call the breastbone, is fairly simple. It's got three basic parts: superior to inferior, the manubrium, the body, also called gladiolus, and the xiphoid process. The manubrium bears a kind of indentation superiorly that's called the jugular notch. And it's also where your clavicles articulate, though you don't see clavicles in this picture, and your first two costal cartilages. So rib 1 connects completely to the manubrium with its costal cartilage, and that is a synarthrotic joint. That one doesn't move. And then your second rib attaches partly to the manubrium, partly to the body of the sternum through that costal cartilage. The body itself is the largest part, actually made up of several smaller segments called sternebrae that fuse together prenatally. And that creates a nice shield for your heart. So that's really good protection because it's directly anterior to much of your heart. Where the manubrium and the body connect is called the sternal angle. And if you palpate your own sternum, you can sort of feel that horizontal ridge where the manubrium and the body connect. This is often cartilaginous where it connects. And it's a significant landmark because notice in the picture, it's directly at the level of the second rib. So your sternal angle is always at the level of the second rib, and that's an easy way to find your second rib and then maybe count down towards other ribs if you need to find a particular place on the thorax. The body receives the costal cartilages for ribs 2, 3, 4, 5, 6, and 7. and those are all considered true ribs because they have a direct connection between the rib and the sternum with just one piece of cartilage. That cartilage, by the way, is hyaline cartilage, the most common type that we have. The xiphoid process is the little projection, most inferior on the sternum. It is made out of cartilage, hyaline cartilage, for a long portion of life. So it makes up the xiphisternal joint with the body, and it is cartilaginous as shown in this picture for up to a good 40 years. I'm not sure why that process of postnatal endochondral ossification takes so long, but it really does take up to 40 years. Sometimes they use that as a means of aging a skeleton if they find skeletal remains and they find a sternum intact with a xiphoid process that is still cartilaginous. That might indicate an individual that was younger than 40, because it's usually fully ossified after 40 years old. And so xiphoid process is really just for abdominal muscle attachment. Okay, we have 12 pairs of ribs, and you looked at the features of ribs in lab. There's a neck, which is the dorsal articulation. I'm sorry, the head is the dorsal articulation, followed by a small segment called the neck, which leads to a bump called the tubercle that has a facet on it, and the facet will articulate with the transverse costal facet of the transverse process of your thoracic vertebrae. The major portion that kind of bends around is called the shaft, or sometimes the body of the rib. And there is a costal groove, or subcostal groove, as we better call it, on the inferior edge of the shaft of the rib. And that can help you side the rib, determine if you've got a right rib or a left rib. Because if you hold the rib on the wrong side, you may have the subcostal groove facing superiorly. And the name tells you that it has to be inferior or under the rib. So every human has 12 pairs of ribs. This is not sexually dimorphic. And 7 of these pairs are known as true pairs of ribs, and 5 are known as false pairs of ribs. The true pairs are called vertebrosternum, because there's a direct connection to the sternum. And the false pairs are called vertebrochondral because they connect to cartilage. So in a true pair, the rib goes from a vertebrae directly to the sternum through one costal cartilage, but the false pairs go from vertebrae to cartilage and then to another cartilage. 7 pairs of true ribs are numbers 1 through 7, and we start counting our ribs superiorly. So the first rib is the most superior one. And then our false pairs of ribs are pairs numbers 8, 9, 10, 11, and 12. Pairs 11 and 12 are also known as floating ribs because they do not articulate with costal cartilages to the sternum at all. So there's no articulation to the sternum at all. They're just kind of floating, hanging out there. And they are the smallest pairs of ribs, 11 and 12. So floating ribs are false ribs. And so these ribs, which form our thoracic cage, articulate dorsally with 2 vertebrae, which is what you're seeing on this lower picture on our screen. You can see the head of the rib is connected to the inferior costal facet on one vertebrae and the superior costal facet of the next one down. And that is also where the intervertebral disc is. And then your tubercle has a facet for the transverse costal facet of the lower of the 2 vertebrae. And that is a typical articulation. An atypical articulation we see, for example, with ribs 1 and ribs 11 and 12, where there is not a pair of costal facets for the head of the rib, but just a single costal facet for the head of the rib. And again, your ribs are going to protect thoracic organs like the heart and the lungs. They're also for muscle attachment, and they allow for respiration through the movement of the thoracic cage that facilitates expansion of the lungs. Okay, so that is the end of the axial skeleton. Moving on now to the appendicular skeleton. So we know the appendicular skeleton is made out of the girdle bones for upper and lower extremity, and then the bones of the upper and lower extremity. So we're starting with the upper extremity, looking at the pectoral girdle. So girdle bones connect the appendage to the axial skeleton. In the case of the pectoral girdle, we're connecting the upper extremity to the axial skeleton. The pectoral girdle is arranged to give maximum mobility to the upper extremity. Now we already know that the glenohumeral joint is a synovial joint. It is a ball and socket with a shallow concavity, so that's diarthrosis. This is really the most mobile articulation that we have. And that mobility is further enhanced by the arrangement of the pectoral girdle. Those are all synovial joints in the pectoral girdle. And the clavicle kind of helps to hold the scapula away from the thoracic cage so that there's room for all of that mobility of the arm. Also, the scapula doesn't articulate with anything other than the humerus and the clavicle. It's really just attached to the body by muscle, so it is able to move a lot. Think about how you can elevate and depress your scapula when you, quote, shrug your shoulders. The whole bone moves cranially and moves caudally. You can protract it, retract it, rotate it. It's very, very mobile because of the way it attaches. The clavicle articulates with the sternum. It's called the sternoclavicular joint. You can see it's connecting to the manubrium of the sternum. That is a synovial joint. That is a saddle joint and a diarthrosis. The acromioclavicular joint connects the acromion of the clavicle, which is the lateral side, to the acromion of the scapula, which is the bony projection at the end of the scapular spine. That is also a synovial joint. That is a plane-shaped synovial joint. So both are diarthroses. There's a lot of movement there. And then we've already described the glenohumeral joint as a shallow ball and socket, maximizing mobility. And remember, when you maximize mobility, you often give up stability, which is why that shoulder joint is somewhat easily dislocated. Okay, so there's your clavicle. You did look at it in lab. Just identified the two separate ends, the sternal end articulating with the manubrium and the acromion end articulating with the acromion of the scapula. The scapula has very distinct ventral and dorsal surfaces. The dorsal side can always be observed because of that big spine that cuts across it. And you can palpate the spine of your scapula if you sort of feel the scapula on your back. You can feel that big bony ridge, the spine. The ventral side of the scapula is just one big subscapular fossa, and that's where the subscapularis muscle will have its origin. The dorsal side, the spine divides the surface into a supraspinous fossa and an infraspinous fossa. Those names are very generous. Supraspinous tells you above the spine, infraspinous below the spine. And we learned early on that a fossa is kind of a big, smooth depression. So those are good names. And you'll see that the supraspinous fossa has the origin of supraspinatus muscle, infraspinous fossa origin of infraspinatus muscle. Origin meaning that is one of the attachments of a skeletal muscle. We can also see the glenoid cavity, an important feature of the scapula. That's the shallow indentation for the head of the humerus, so that forms the glenohumeral joint. Then you can see some other features on the scapula that you looked at when you studied the bones for lab. The scapula articulates only with the head of the humerus at the glenohumeral joint and with the clavicle at the acromioclavicular joint. As I said before, it's otherwise attached only by muscle and is therefore able to move quite a bit. Okay, bones of the upper extremity. So you have the arm, which makes up the portion of your upper extremity between the shoulder and the elbow. contains a single bone called the humerus. You identified many of these important features in lab: the head of the humerus, the greater and lesser tubercles, the medial epicondyle at the distal end, the capitulum and trochlea at the distal end, and then also at the distal end, the olecranon fossa, the big indentation on the posterior side. The humerus articulates at its head to the glenoid cavity of the scapula. And then distally, you have two condyles, two projecting rounded surfaces. One is called the capitulum, that's the more laterally positioned one, that articulates with the head of the radius. The trochlea articulates with the trochlear notch of the ulna. And together, those last two articulations form your elbow joint, which, if you remember, is a hinge joint, allows for flexion and extension of the forearm. The bones of the forearm, and remember the forearm is the portion of the upper extremity from elbow to wrist, are the radius and the ulna. The radius is the lateral bone, the ulna is the medial bone, and the radius and ulna both articulate with the distal humerus to form the elbow. The radius and the ulna also articulate with each other proximally and distally. So we have a proximal radioulnar joint and a distal radioulnar joint, and those two articulations create the pronation and supination that turns the hand. The radius is the lateral bone of the forearm, and its proximal end is a big circle. And if you are familiar with the term radius as the distance halfway across a circle, that might help you remember that the radius is the bone that has the big circle at the end of it. It also has a radial tuberosity. Tuberosity is a bump that's on the proximal anterior side of the radius, and that's going to be for the insertion of your biceps brachii muscle. Distally, the radius has a little styloid process, and also what's called the ulnar notch, which is where the head of the ulna will articulate. So the radius articulates proximally with the ulna, distally with the ulna, and then the distal radius, and you notice it widens distally, articulates with a couple of the carpals at your wrist joint. Okay, the ulna is the medial bone of the forearm. It has a hook, which if you hold the hook sideways, kind of looks like the letter U. So the ulna is the one that looks like a U. That's the proximal end. The indentation of the hook is called the trochlear notch, the inferior pointy part coronoid process, and then the big kind of bulky part that you think of as your elbow bone, that's the olecranon. There's also a radial notch where the head of the radius articulates. Distally, you have the head of the ulna, which is a small rounded projection, and then a styloid process. So notice there's a styloid process at both distal ends of the radius and the ulna. The radius and the ulna articulate both proximally and distally, and then also the ulna articulates proximally with the humerus to make the elbow joint. And then you can see that the radius and the ulna are connected together at what's called the interosseous membrane. Interosseous tells you between bones. That is a syndesmosis. That's a solid articulation with a ligament. So that is a syndesmosis. Because these bones pronate and supinate, the syndesmosis is functionally considered a diarthrosis because you have that wide range of movement. So the interosseous membrane is a syndesmosis joint, which is solid, fibrous, and in this case, a diarthrosis. Okay, 3 kinds of bones in the wrist: metacarpals, where the palm of your hand is, and phalanges in your fingers. We have 8 carpals in each hand, in each wrist, and they articulate together at intercarpal joints. A couple of them also articulate with the distal radius to make the wrist joint, where we move the hand. And then 4 of them articulate with the metacarpals. The intercarpal joints and the metacarpal joints are plane joints except for the carpal metacarpal where your thumb is. That's the saddle joint that gives your thumb opposition. You have 5 metacarpals. Again, these are making up the palm of your hand, and they articulate with the distal row of carpals as well as the proximal phalanges. The articulation between the metacarpals and proximal phalanges, those are your knuckles. So you can follow along on your own hand looking at the joints. And then you have 14 phalanges per hand. That's 3 phalanges in fingers 2, 3, 4, and 5, and 2 phalanges in your thumb. So thumb is considered number 1 when you're counting fingers. And so proximal, middle, and distal phalange in each finger 2, 3, 4, and 5, but only a proximal and distal phalange in your thumb. Your interphalangeal joints are straight up hinge joints that allow for flexion and extension. The position of your thumb, of course, is going to give the ability for opposition, along with that trapezio-metacarpal joint, which gives you a wider range of movement. The other carpal metacarpal joints are plane joints, which we know don't really move a lot. Okay, let's take a break. Okay, appendicular skeleton, now pelvic girdle and lower extremity. So again, girdles connect the appendage to the axial skeleton. Now we're looking at the attachment for the lower extremity. So we have 2 pelvic bones, also called coxal bones or os coxa. Coxa is the root meaning pelvis. And each os coxa is formed from 3 parts that will fuse together prenatally a little bit into early postnatal development. The 3 parts are the ilium, ischium, and pubis. And you can see in this picture, they show you the 3 portions with coloration. So you can see the kind of divisions among the 3 parts. You can also see where the 3 parts articulate to each other. Notice one of those points of articulation or fusion is right inside the acetabulum. So the acetabulum is part ilium, part ischium, and part pubis. The ilium is really the superior portion. When you put your hands on your hips, you're resting your hand and feeling your iliac crest, as we call it. The ischium is the inferior posterior part. It bears that big ischial tuberosity. I call that the butt bone. When you're sitting down, it's largely exposed. You can kind of feel it against a hard chair, for example. And the pubis is the inferior anterior part. So you learned various features of the ilium, like the iliac crest, like the iliac fossa, like the auricular surface. Features of the ischium include the ischial spine, the ischial tuberosity. On the pubis, you learned the pubic crest and the pubic symphysis, or the symphysial surface. Some features are formed from more than one part. As we just noted, the acetabulum is from all 3 parts, and that is the big socket for your head of the femur. So that makes the ball and socket joint at your hip. Another feature that is made from 2 parts is the obturator foramen. That's the big hole that you see in the os coxa, and that is formed part from ischium and part from pubis. So the os coxa articulates with the head of the femur at the acetabulum. One pubic bone articulates with the other pubic bone to form the pubic symphysis, and that is a symphysis which describes the fibrocartilaginous solid joint. Functionally, your pubic symphysis is an amphiarthrosis, allows for some movement. And then each ilium articulates with the sacrum at the auricular surface. That sacroiliac joint, as it's called, is a really broad weight-bearing, weight transfer joint. So weight comes down the sacrum and goes through those joints to the ilia and then down to the lower extremity through the pelvic bones. Those sacroiliac joints are synovial joints, and the shape there is a plane joint. The whole sort of pelvis together, the pelvic cavity, is formed from two of those os coxa or coxal bones, plus the sacrum and the coccyx. So that makes kind of the collective structure that we call the pelvis. And these have two openings associated with them, kind of like the thoracic cage did. On the thoracic cage, we had a superior thoracic aperture and an inferior thoracic aperture. Here we call the openings the pelvic inlet and the pelvic outlet. The pelvic inlet is the superior opening, and the pelvic outlet is the inferior opening. The pelvic inlet is where organs might move between abdominal cavity and into the pelvic cavity, like your sigmoid colon, for example, which is part of your digestive tract. The pelvic outlet is a space that is going to be sealed with skeletal muscle and soft tissue, and is going to allow structures to pass to the outside of the body. So your anal canal goes through the pelvic outlet, through the musculature of the pelvic outlet. In a female, the vaginal orifice goes to the outside of the body through the muscular floor of the pelvic outlet. So the pelvic outlet is sealed, much like the inferior thoracic aperture is sealed with muscle. And also the pelvic inlet is always open, just like the superior thoracic aperture is always open for things to move through. When we look at the bony pelvis, we can distinguish the true pelvis from the false pelvis. The true pelvis is really the pelvic cavity. It's the space essentially between the pelvic inlet and the pelvic outlet, and that is where, for example, an unpregnant uterus would be situated, completely surrounded by bone. Because the bones of the true pelvis really don't have a lot of give to them, anything that needs to develop and get large that's in the true pelvis is going to have to leave the true pelvis, like a pregnant uterus. So an empty uterus or an early pregnant uterus can still fit inside that true pelvis, but once it begins to expand, it needs to go up through the pelvic inlet into the abdominal cavity, which has muscular walls that can be pushed out and stretched out. And so that's why a baby develops up in the abdominal cavity and not in the true pelvis, which is totally bony. The false pelvis is that space superior to the pelvic inlet, still near the ilia, so associated with the bones of the pelvis, but not within the true pelvic cavity space. So if you think about your urinary bladder, when it's empty, it's in the true pelvis. After your 72-ounce Slurpee at Cumberland Farms, when your bladder begins to fill with urine, it's going to expand cranially, and it's going to rise up through that pelvic inlet and be situated near your ilia. That would be the false pelvis. So it's still associated with the bones of the pelvis, but outside of that contained bony space. So we do have sexual dimorphism of the pelvis in humans. Remember, sexual dimorphism, di, two, morph, form, two forms that we find sexual meaning between the male and the female. And you can see some of the characteristics that describe the female state versus the male state. So the structures of the pelvis are a little bit different in the male versus the female. And this is, of course, because the female pelvis has to support a pregnancy and deliver a big-headed human baby. So you can read the details here, but basically the purpose of the dimorphism in the female, the changes to the female pelvis, are to accommodate delivering a baby. And really what they're doing is making that pelvic outlet bigger, less obstructed. Remember, we talked about the coccyx in a male curving sharply and blocking some of that space in the pelvic outlet. That would make it very difficult for a baby to get through that space. So the dimorphism of the coccyx in the female is that it is straighter, it hangs back, It does not block the pelvic outlet. So the dimorphism described here between the male and the female, again, largely making a bigger pelvic outlet for the baby to be able to fit through. You can read more about that in the lab manual as well. You can see here from this inferior view, there's a much bigger space for a baby to get through in the female than there is in a male. And that's the shape of the pelvic outlet that you're looking at from this view. Okay, just like the upper extremity had divisions, arm, forearm, and hand, the lower extremity has divisions, thigh, leg, and foot. So the thigh is analogous to the arm. It's the region from hip to knee. The leg is the region from knee to ankle. And then the foot is going to have 3 kinds of bones in it as well. In the thigh, you have a single bone, the femur, biggest bone of the body. It is the largest bone that we have, strongest bone. And that's, of course, because it's doing all that weight bearing, transferring the weight from the axial skeleton down through the lower extremity to the ground. Some of the big features that we looked at are the head of the femur, big rounded spherical head, and that's going to create the ball and socket joint at the hip, which is still very mobile, but also more stable because of that weight bearing function that it has. It's followed by a neck, and then we see proximally a couple of sort of sharp projections, the greater and lesser trochanters. Those are for muscle attachment, the gluteals largely attached there. There's also a gluteal tuberosity for gluteus maximus. And then along the diaphysis of the femur, we have the linea aspera. That translates into roughened line. It's sort of a roughened ridge that runs along the dorsal side of the femur's diaphysis. And that's going to be for attachment of largely the adductor muscles in the medial compartment of the thigh. At the distal end, you have a couple of big condyles, medial and lateral condyles, and those create the articulation with the knee. On the anterior distal end, you see the patellar surface, and that will articulate with the patella. The patella bone shown on the left of the picture is called a sesamoid bone, meaning it's sesame seed shaped. And we don't have any analogous bone in the upper extremity. It helps to protect the kneecap, and it also improves the leverage of your quadriceps muscle, which is the big muscle group in the anterior thigh that's going to extend your leg. The femur articulates, again, with the pelvis proximally, ball and socket joint, and distally with the tibia, making up the knee joint. And the knee joint is called a modified hinge joint. A hinge joint should be uniaxial, only allowing flexion and extension, but the knee actually has a little bit of rotation that occurs when you are fully extended and you need to begin to flex your leg. There's a little bit of rotation that has to occur to put the tibia in position to be able to flex. So because we have biaxial movement at the knee, 2 degrees, one from flexion and extension, and then one from that little bit of rotation, it's a modified hinge joint because a true hinge joint is only uniaxial. In the leg, like in the forearm, we have 2 bones. In the leg, our medial bone is called the tibia and our lateral bone is called the fibula. When you look at these 2 bones, the tibia kind of looks like a T. It's the bigger bone and it broadens proximally, which kind of gives it that T appearance. The fibula is the lateral bone and it is kind of thin and stick-like, almost like a lowercase letter L. So that might help you remember that the tibia looks like a T and the fibula, which has the L in it, kind of looks like an L. Tibia is in the medial position. It has 2 big condyles at the proximal end for the condyles of the distal femur. That makes your knee joint. It also has a tibial tuberosity on the anterior side of the proximal end. That's going to be for the insertion of your quadriceps tendon or the patellar ligament that connects from the quadriceps tendon. And then distally, it has a medial malleolus. That's your inside ankle bump that's going to help to support the ankle joint. And then it also has facets for the fibula, both proximally and distally. The fibula is the thin, stick-like L-shaped bone on the lateral side. It articulates both proximally and distally with the tibia. Notice it does not articulate with the femur at all. Does not articulate with the femur at all. That means that it is not doing any weight transfer, any weight bearing. All the weight that comes down your femur goes directly into your tibia, which is why it's broader and bigger and thicker, actually considered the second biggest bone of the body after the femur. The fibula is flimsy and thin and stick-like, can't support any weight. It is only for muscle attachment, and distally it's going to reinforce the ankle joint with its lateral malleolus. Malleolus means little hammer. So those two projections that make up your inside and outside ankle bump are your little hammers. They reinforce the ankle joint. Between them, there is an interosseous membrane, just like we had between the bones of the forearm. It's structurally a syndesmosis, which is a solid ligamentous joint. Remember, functionally, the interosseous membrane of the forearm was a diarthrosis because of that pronation and supination that it facilitated. In the leg, however, we don't have pronation and supination. We're not able to move the foot that way. And so it is a synarthrosis here in the leg. Same kind of structure, but a different functional category because of the difference in articulations. The proximal tibiofibular joint is a synovial plane joint, but the distal tibiofibular joint is another syndesmosis. So it is attached not with a joint cavity, but just by a little ligament, and that makes it an amphiarthrosis, just has slight give there as well. Okay, your foot has 3 types of bones, just like your hand did. Instead of carpals and metacarpals, we have tarsals and metatarsals. You don't want to get those words confused. We had 8 carpals in each wrist, but only 7 tarsals in each foot. But the tarsals make up a good half of the size of your foot, whereas the carpals were a very small portion of the size of the hand. So your 7 tarsals make up the posterior half of your foot. They articulate at intertarsal joints, which are synovial plane joints, and they actually move around quite a bit in that nonlinear gliding sort of way. They do create the inversion and that our bipedal locomotion evolved in bare feet. Right? So nobody was wearing shoes when we learned how to navigate uneven ground on just 2 feet. So those intertarsal joints allow for our foot to conform and grip on a little bit to uneven surfaces. We have 5 metatarsals, just like we had 5 metacarpals. Again, they're making up part of the anterior half of our foot. They articulate at plane joints to the tarsals proximally, but then at condyloid joints, those are like our toe knuckles, distally with the phalanges. We can flex and extend and abduct and adduct the toes there. You'll notice that your toes have the same distribution of phalanges that your hand had. So you have 2 phalanges in your big toe, which is comparable to your thumb. It's called the hallux. The fancy word for your thumb is pollex. And then you have 3 phalanges in toes numbered 2, 3, 4, and 5. So again, the thumb is finger number 1, your big toe is toe number 1. So same distribution, 14 phalanges per foot, just like 14 phalanges per hand. But the position of your big toe is clearly different than the position of your thumb. The position of your thumb is unique, and it has that unique saddle joint that gives you opposition to allow for fine motor control. So you can manipulate and carry out what's called the precision grip, delicately holding something between your thumb and your fingers, and you can then sign your name in cursive or thread a needle. Your thumb does that, but your big toe does not. Your big toe is aligned with all your other toes, and that makes your foot a much better lever. That facilitates your bipedal locomotion on the ground. So we are terrestrial. Our feet are going to stay on the ground for our typical moving around. And so we need that big toe lined up with the other toes to be a more kind of solid support for the foot and to provide a spring-like lever that can push the entire body forward. Our foot also has a series of arches. So the foot from a lateral view is not flat inferiorly, it is curved. It has arches, 3 arches per foot. A medial longitudinal arch, which runs kind of anterior posterior, a laterally positioned longitudinal arch, anterior posterior, and then a transverse arch, which runs sort of in the medial lateral direction across the foot. You can see those in the picture here. These arches give our foot kind of a proverbial spring to our step. They're maintained by the way the bones articulate and the way the ligaments and muscle tendons connect, support that curvature. And the curvature allows the weight of the body to kind of be absorbed and then redistributed, and kind of allows the foot to push off and spring back and resume its curved structure. And so it really facilitates our bipedalism. All the weight goes through our body, through the vertebral column, through the sacrum, through the hip, down the lower extremity, through the foot, right onto the ground. But as we use our foot as a lever to propel ourselves forward, the arches provide us with a little bit of recoil almost, so that we're able to kind of continuously move forward. So it's important for our bipedalism to have these arches to our feet. If your arches are structurally compromised for whatever reason, that's when you're known to have flat feet. So those are all the bones of the skeleton. Just a couple quick words on the effects of aging. We've talked about some of this before when we looked at our bone and cartilage tissue. Cartilage, we know, can lose some of its normal consistency if it becomes calcified. We talked about calcium. Crystals being deposited in the matrix of cartilage, which should not have those there. The cartilage matrix should be watery and gelatinous, but if calcium deposits are left there, then it makes the tissue hard and rigid and really unable to do its job, and that has similar effects like arthritis. Osteoporosis, we've talked about, is a reduction in the mass of bone tissue. So you can see those demonstrated in this picture here. When your osteoclasts are working faster than your osteoblasts, so you're breaking down more tissue than you're replacing, then you lose the density to your tissue, and you can clearly see it's much thinner. There's some holes in it in those pictures shown on the right. There's an important influence of sex hormones to this condition, and that's because sex hormones facilitate bone depositing, so they stimulate osteoblasts to make more bone tissue. And in females, the production of sex hormones declines earlier than it does in males. So let's say, estrogen has a role in bone deposition, and estrogen becomes less abundant in females starting at age 40. That's going to have a long-term effect on their bone deposition and their bone density and their bone strength. In males, if the sex hormone influence doesn't really have a demonstrated effect until 60, when their sex hormones show a reduction in production. Then their bone tissue will remain stronger and healthier later in life. So more females are prone to osteoporosis than males because they have a reduction in their sex hormone production earlier than males do. And so to try to counter the effects of this loss of bone tissue, exercise and weight-bearing exercises especially are important. Remember that muscles pulling on bones, as will happen when you're exercising, is a stimulus for bone tissue production. Vitamin D and calcium are important for maintaining proper bone tissue, for minimizing the osteoclast activity required to get calcium into your blood for other body systems. So the more you introduce, the less has to be released from storage in your bone tissue. And then in severe cases, there can be drugs used to inhibit osteoclasts, to slow down osteoclasts, which are breaking down bone tissue. So these are some of the effects of aging. As we know, everything kind of deteriorates overall, but these are some of the specific effects to bone tissue through time and some of the treatments to prevent or counter those effects. And so as we go through other systems of the body, we want to ask about how each system interacts with the other systems to carry out different parts of homeostasis, how they work together to keep us safe and healthy and alive. So what do the integumentary system and the skeletal system have in common? I'm sure you're shouting out answers right now, but we know that they both protect. We talked about the ways that the skin protects mechanically from ultraviolet rays, etc. The skeletal system definitely protects as well through its hard calcified organization, provides physical protection for soft internal organs. Skeletal system and muscular system work together for protection, again, because muscle does provide some walls to body cavities like the abdominal cavity, but skeletal and muscular system really work together for the movement of the body. We know that skeletal muscle attaches to bones, pulls on bones to make different body movements occur across joints. So we'll look at more of that in the next muscle lecture. Nervous system really helps to regulate all of our kind of bone maintenance for sure. And endocrine system, specifically at the tie between endocrine sex hormones and bone tissue production. Remember, we also talked about the role of parathyroid hormone and calcitonin in regulating calcium levels, which of course affects bone tissue. Cardiovascular system, well, we know that bone contains bone marrow, which is where our blood cells are produced, so that's a good one. Also, we know that the blood is going to transport calcium and other phosphate things that are released from the bone tissue through the blood to be delivered all over the body. Bone tissue is also highly vascularized to support its metabolism. Digestive system, we know that we take in a lot of calcium through our digestive processes, and calcium is important as it is stored in the bones. So we have that connection there. Our teeth also part of the skeleton, important for digestive processes, as is mastication. So chewing up that food, which is mechanical breakdown of food, is done by the mandible and that modified joint, temporomandibular joint, modified hinge joint. So teeth and mandible are important for the digestive system there. And reproductive system, we talked about the dimorphism of the pelvis, critical for females delivering large-headed human babies, and then reproductive hormones also playing that role in bone tissue. So those are some of the major connections between different systems. I didn't put respiratory up there, but we did talk a lot about how the rib cage and the thoracic cage is important for respiration, the movement for the expansion of the lungs as we breathe. So that's another kind of major connection as well. So that ends our skeletal chapter, and you can look for the next lecture to be posted soon.